Okay, so go through these unknowns. So the first one is just prototypical psoriasis. Now it's not perfect psoriasis, but as many staff have said, if you were to actually get a biopsy, so if you do derm path, you don't really see classic psoriasis, because classic psoriasis clinically you don't really need a biopsy because it's so classic. But the important things to pick up from this chapter are, what are the classic features? How can I make sure I get it right on the board exam? And how can I distinguish it from other things that look like it? So MF and tinea and PRP and things of that nature. So in going through the classic features of psoriasis, what you want to see is regular acanthosis. And as you guys probably know, that what that means is basically everything's basically about the same, thickness. Even the reading themselves are roughly kind of bulbous and similar at the end. Sure, some of these are kind of a little more slender, but generally speaking, they're all pretty close in terms of size. And that regular acanthosis, one way to remember that, of which one goes with which, regular acanthosis with psoriasis, irregular acanthosis goes with LSC. One way to remember that is, psoriasis is happening from the inside out. That's something systemic, and so it's kind of affecting the skin all at the same time. Whereas LSC is irregular because you're kind of doing it to yourself from the outside in. And so you can imagine, we don't scratch the skin perfectly the same way every single time. And so underneath the skin that manifests itself as more of this irregular, funky acanthosis, so if that helps you. So you see regular acanthosis. You want to see confluent parakeratosis with layering of neutrophils within. Now this one you would hope to be a little bit crustier. Let's see if I can look at the other cut. Find it. See, this area is a little bit more follicular, but if you get down in here, you can see that there is para. And again, this isn't the best ever. You like it like in the book, where it's this huge, thick plaque. And you've got parakeratosis that goes left to right, that is confluent. And then within, you get layering of neutrophils. So we call this the sandwich sign, or I like to call it more the lasagna sign. But basically, when you see that layering, that confluent parakeratosis with layering of neutrophils, that really suggests psoriasis. But as you guys also probably know, that really brings up a differential. And so lots of things can look psoriasiform. And anytime you see newts in the horn, that's where you want to think of that P-trix or P-tix differential. So P-trix is the way I memorized it. But psoriasis, tinea, reactive arthritis, impetigo, candida, syphilis, sebderm. You want to think of all those things because they can all look very similar. And there's some subtle clues that help you tease that out, and that's kind of what we're going over today. But generally speaking, if you see newts in the horn, you have to consider all those things. Well, let's go back to the overall features. Find that other cut because I liked it better. So, again, getting back to just general features of psoriasis. So confluent parakeratosis with layering of neutrophils. You do not see serum crust or a whole lot of oozing and stuff that's there in the horn, because that doesn't really occur in psoriasis. You really don't see a whole lot of spongiosis in the acanthosis in the epidermis itself. Maybe a little bit here and there, and of course, Elston loves to ask, what are the types of psoriasis that you get more spongiotic changes to the epidermis, since that's classically going to be acral, inverse, erythrodermic, stuff like that. So you can see some sponge, but generally speaking, you don't really see hardly any spongiosis. You don't see much of an infiltrate, so that's very important. With psoriasis, you really should just see a little bit here and there, kind of perivascular, subtle lymphocytic infiltrate, but certainly not a whole, a pronounced infiltrate. And then you get a, thinning of these suprapapillary plates, so right above the dermal papilla. Now that, some authors will tell you that that's actually not true. It's more of a optical illusion. It appears that this is thinned. It certainly looks thin to me, but it's actually because of the acanthosis. And in fact, this is sort of normal. It's just that because of the acanthosis, it looks thinned, whereas different from pityriasis rubopilaris and some other things where you actually get true thickening of that suprapapillary plate. So it is helpful to distinguish, but it's not necessarily a guarantee. But generally speaking, we think of that thin suprapapillary plate. You get dilated vasculature. That's what corresponds with like the Auspitz sign, which we don't really look for anymore, but if you pull off a flake, you get the bleeding that's easy. And you do not see a whole lot of fibrosis down here per se. So those are all kind of the main features of psoriasis and what you're looking for. And psoriasis can start, a lot of times it starts kind of around the follicles, so follicular psoriasis. But anytime you see sort of plugging per se, you want to say, oh, well, is this PRP? And then you kind of want to start thinking back and forth of is it psoriasis, is it PRP, is it more subderm, things of that nature. So that's just run-of-the-mill psoriasis.
Bless you.
Bless you. Okay, now this one is pustular psoriasis, and this one, almost even more so than the last, really brings up a differential. So, if the clinical differential that I received when I'm reading this slide was pustular psoriasis, then I would give that back and say, yeah, they're certainly consistent with pustular psoriasis, and certainly that sounds like that fits great. However, really this brings up a differential, and it's the subcorneal pustule differential, and so that's going to be a broader differential than just P-trix. And by the way, in psoriasis, which we didn't really see in the last one, but there are you certainly can get sort of the intracorneal pustules, the Monroe microabscesses. You can get the intraepidermal pustules. So if it's more in the epidermis itself, little collections of neutrophils. That's the spongiform pustule of Kagoi. And so those are other things that help support a diagnosis of psoriasis compared to lymphocyte collections in MF, Papillary microabscesses, or just Langerhans granulomas and spongiotic derm issues. So the little collections of neutrophils can be helpful, but when you have this very well pronounced subcorneal pustule, that's more of its own differential to include pustular psoriasis. So the one that I learned, I think in the book he has cat piss or cat sips or whatever, which that works pretty well. I learned smart picks, and so that's Sned and Wilkinson, subcorneal pustular dermatosis, miliaria, AGEP, and reactive arthritis. It of course includes a lot of P-trix stuff. Tinea, psoriasis, impetigo. The T is also transient neonatal pustular melanosis. The A is also includes acral pustulosis of infancy. And then Candida, syphilis, subderm. So, it includes a lot of those same things, but it's all stuff you want to be thinking of in the differential when you see subcorneal pustules. You always want to look for tinea. So with those sorts of, when you ever see those newts in the horn, a lot of times we end up staining it to rule out tinea. Okay. So this next one is guttate psoriasis. And this one, a lot of times with guttate psoriasis, we actually see almost even smaller little plaques or smaller little collections of parakeratosis with neutrophils on top. But you can see how this one clinically, it would just be this little guttate, little teardrop, scaly plaque all over the person's body probably. And as it occurs more abruptly, you don't necessarily get all that acanthosis, and the surrounding area is very, very normal. You can get more spongiosis in the guttate form, and so that's possible. You don't really see a whole lot of spongiosis here, but again, that's included. And really, it's very similar though otherwise to psoriasis. You would want to see a mostly confluent parakeratosis with then layering of neutrophils. Although with guttate, we like to say that the neutrophils are on top. It's kind of like the jelly up sign. If you think of like a sandwich that you got to put jelly on, it's just sort of the top. So that's one way to think of it. But you still have to include all the same things in the differential. So all the P-trix stuff. So yes, this could be psoriasis, but it still could just be tinea. It could be subderm, candida. So you have to look for all those things. But this is pretty good for guttate psoriasis. Okay, number 4. straight up and down. Like Dr. Russell says, you should be able to recognize things upside down, but it's still nice to have it right side up, in my opinion. So this is Psoriasis rosea, and the salient features of PR. Let me find, there's a really good cut in here somewhere. We'll go with this one. Okay. So, as you guys know, Psoriasis rosea, you get, it's in the annular differential, and you get the expanding rings of erythema with a trailing scale. And so that corresponds very well with what you see histopathologically. And so you get these little foci of parakeratosis. And this is probably one small little annular ring that was biopsied. And that parakeratosis is the trailing scale. And that's what's going to correspond clinically to the scale that you actually see. And so then what you hope to see, microscopically in a textbook case, is you hope to see at roughly a 45-degree angle, very roughly, you see some spongiosis, which you can see here. It's kind of right underneath it. But let's just imagine it's kind of 45 degrees. And then 45 degrees from that, you see a focus of a predominantly lymphocytic infiltrate, likely viral mediated. Of course, we still think it's probably HHV6 or 7. But you get this lymphocytic infiltrate around the vessels. And relatively sparse infiltrate everywhere else. Maybe there's a little bit here and there, but I think in one of these cuts it's a little bit more pronounced. But that's basically what you see for Psoriasis rosea. So more spongiosis than what you'd see in other things. You don't typically see a whole lot of newts in the actual horn itself. It's really just sponge, lymphocytic infiltrate, roughly at a 45-degree angle. The features are usually fairly subtle, which from the dermapath side we like to say if you have to hunt around for a while for it to turn it into PR, pretty good chance it is PR because it can be very subtle. Sometimes we like to talk about the teapot sign, which is basically where this little focus of parakeratosis, for whatever reason, kind of lifts off on one end. So if you imagine this end kind of pushes up a little bit. So then it's at an angle, almost like a little teapot that sort of comes up. So I don't know why that's, found in Psoriasis rosea, but that's something that we like to talk about. So that's Psoriasis rosea. Always looking for new fun things. Classify stuff, I suppose. Okay, so this next one is Ilvin. Try to get this right side up as well. And this is in the psoriasiform differential. Let's clean off this slide, sorry. Because it certainly can look very psoriasiform, as you saw there. Much better. However, there's some very important differences. So certainly you get acanthosis, and it can be very regular. And overlying that, you've got a pretty pronounced area of parakeratosis. It's orthokeratosis elsewhere, kind of around the periphery, but a lot of this is this confluent parakeratosis. So you may be tempted to say, oh, it's probably just psoriasis. But if you look down in there, which we'll hear in a second, there's really absolutely no neutrophils. And that would be certainly very, very odd and make psoriasis much less likely. And so really you just have confluent parakeratosis and then a fairly regular acanthosis, but no infiltrate, no neutrophils. There's a little bit of serum crust in here, which doesn't necessarily mean anything, but that further goes a little bit against psoriasis. But then you start to notice that there's these columns of orthokeratosis, and it's sort of alternating from left to right. So it's not checkerboard pattern. It is just columns kind of left to right. And when we go down a little bit deeper, it becomes a little bit more noticeable. Do this without having the slide fall in. And so here you can really make out those the columns going from left to right. And underneath the orthokeratosis, you get hypergranulosis, or at least retention of the granular layer. Whereas underneath the parakeratosis, there's loss of the granular layer. And that is normal. And so I think I alluded to this many, many chapters ago. But normally when you have, like here on the left, when you have orthokeratosis, that's a thickening of the that stratum corneum, but it doesn't mean that it's necessarily proliferating much more rapidly than elsewhere. And so you're still getting normal creation of the granules, and then normal kind of maturation in a sense and loss of the nuclei for the keratinocytes as they move into the stratum corneum. And so that's normal. Whereas when you see parakeratosis, the reason why that occurs is because it's proliferating, like in psoriasis and other things, so rapidly that it doesn't have time to create the granules, and in fact the nuclei are retained, and so that's why you see parakeratosis. And so it is normal for underneath para to see loss of the granule layer and underneath ortho to see retained granule layer. There's really two main exceptions to that, and one of the exceptions is where if you have parakeratosis but you still see granules underneath, that goes with granular parakeratosis, which we'll see here in a minute. And then if you see orthokeratosis, but there's complete absence of the granules, does anybody know what that goes with?
Ichthyosis.
Exactly, ichthyosis vulgaris. And so those are kind of the two main exceptions. There are some subtle variations, meaning that sometimes with Bowens, you can get the million horn, but still, so there's other stuff, but generally speaking, those are two really good exceptions to be aware of, and something they may throw on your boards. Like ichthyosis vulgaris, for example. Okay. So this one is mycosis fungoides, and it's in this box or in this chapter because it can certainly look very psoriasiform. Now this cut does not necessarily look very psoriasiform, and in fact you have this huge ulcer over here, and so that doesn't necessarily make sense for psoriasis. Psoriasis shouldn't really be ulcerated per se. Over here you can kind of imagine, maybe there's some acanthosis going on there, so we'll just play along and say this is psoriasiform. But what is odd is that underneath there is this lichenoid band of inflammation, which we went through the prototypic psoriasis case, and that should not be seen in psoriasis. So let's get in a little bit further. And so once again, you can see here there's some things that are very odd that would go against this being psoriasis. First, there isn't really marked production of the stratum corneum. This is more of a compact orthokeratosis. There's probably some para in there as well, but you're not seeing thickened confluent parakeratosis. There's likely no neutrophils in that stratum corneum. We'll check here in a second, and if there may be just a handful, maybe because there's secondary impetiginization or something. So no confluent parakeratosis, no neutrophils. You have retention of the granular layer, in fact, which would go more with that compact orthokeratosis because you lose the granular layer typically in psoriasis because of all that parakeratosis. There's a hint of spongiosis in here, but not a whole lot. Certainly not enough to justify all of these lymphocytes, and that goes very well with mycosis fungoides. So lots of lymphocytes, but not a corresponding spongiosis that you would expect. I actually learned recently of a sign in the Ackerman book. He talks about the Dolly Parton sign, which is kind of funny. Maybe not something you can say that much these days, but basically the point is that you have a little bit too much of something, which being the lymphocytes in this case, that don't seem to correspond with the rest of that something, meaning a lack of spongiosis. So you can think of that however you wish. But
that was published. Okay.
Yeah, it was published. It was in a book. So did not make that up. So again, getting in a little bit further, you can see here this is not parakeratosis. There's really no newts up here. There's retention of the granular layer. There are lots of lymphocytes kind of percolating up into the epidermis. And then, in fact, as you look closer, you see that they're tagging the DEJ, and there's basically, it's the length in every hole differential. And then this can take a while to really get the eye for this, but a lot of these lymphocytes look atypical, and particularly the ones that are tagging the DEJ and are in the epidermis. They're hyperchromatic. Some of them are almost as large as, if not larger than, the keratinocytes, which is very, very typical because typically lymphocytes are very small. So you have some, maybe a little more normal lymphocytes in here, but then some of these guys that are also probably lymphocytes are very large and either hyperchromatic or in this case it's kind of more like gray and vesicular and just atypical, weird looking. And just this whole infiltrate looks odd. And so that goes certainly more with mycosis fungoides. You would also look for other things to help yourself feel better. This is MF. You'd want to look for the belly up sign, where it seems like the lymphocytes are just, maybe you can see it over here, they're just sort of percolating up from the tops of the vessels instead of all around like you would expect from just a normal infiltrate. The other thing that goes with mycosis fungoides that does not go with psoriasis or other things, which it's kind of hard to see here, but it's papillary dermal fibrosis. And so it's hard to see that too sometimes, but there's a lot of fibrosis in here, which, along with the compact horn, kind of belies more of a chronic process, which you can imagine with MF, more of a chronic smoldering process, and not something you would see with just a spongiotic, process or something of that nature, which would be, in your differential. So that's MF. Okay, flip this around. So this one is just acute spongiosis, and this brings up a differential as well. Now this slide has been damaged a little bit. It's not looking too great currently. The stratum corneum is all sort of broken apart. That's just from the way this tissue is processed and whatnot. So that's not a normal feature per se. And obviously the big thing here are these huge intraepidermal vesicles. And so you can imagine as these get bigger, that's what you're seeing clinically, as these actual big, huge spongiotic vesicles. And from scan, that's kind of the obvious things. That certainly puts you into the kind of intraepidermal vesicle spongiotic acute sponge differential. And from scan, you see a lot of red stuff, which you think, is this erythrocytes, just red blood cells everywhere? Is it like a bloody process or something? And certainly there are, erythrocytes in here. However, the majority of these red things are all eosinophils. And so it really brings up more of it then kind of pushes you into the eosinophilic spongiotic differential, which again, there's different things for that. The one I memorized was happy eats. And so, that's herpes gestationis or bullous pemphigoid pregnancy, arthropod, pemphigoid, pemphigus, incontinentia pigmenti, ETN, what's the other A?
Allergic.
Yeah, allergic contact. I don't know why I figured that. So allergic contact derm is going to be the more common one. Atopic dermatitis, tinea, and then scabies, which is basically arthropod. So that's really all you can say from this. You can't say anything else unless you see an obvious scabies up here or something. This is just an eosinophilic spongiotic process, and it brings up a differential. But that is really good for acute. You can see how this is very, very different from something that's more chronic. These are acute vesicles that have formed. Because that did look somewhat like acral skin, and maybe some of those were squared. This is kind of more of a subtle clue, but if you see acral skin and squared off vesicles, that is supposedly a little bit more indicative of true dyshydrotic eczema or Pontholox. But again, that's more like a derm path thing, I suppose. So this is nutritional deficiency dermatitis. Now, this is actually a really good slide of it. As Elston says in his book, unfortunately, it's not usually this classic. So, when you guys are doing getting an inpatient consult and that crosses your mind, which is one of the many reasons why dermatology is so valuable, because it does not cross the mind of many other people. But you have to think of those nutritional deficiencies, not just acrodermatitis enteropathica, so zinc, but biotin and essential fatty acids and all these other things can create a very similar dermatitis. And so by looking at this cut and the findings here and saying, it's nutritional derm, that doesn't point out what is deficient. So glucagonoma, pellagra, acrodermatitis enteropathica, they all produce kind of the same dermatitis. But usually when it gets biopsied, unless it's kind of been there for a while, it's just a non-specific dermatitis. There's not really a whole lot that's going on. But if it's been there a while, you then start to see this pallor. And essentially what's going on here is you get this somewhat compact stratum corneum, which is the top part here. That always means something that's kind of subacute, almost chronic. It's been going on for a while. And then this is epidermis, and it's just starting to necrose. So the upper half of the epidermis is necrotic, whereas the lower part is largely still viable. but there's not a whole lot of anything else going on. There's not really an infiltrate. There's nothing else that really would seem to explain the that necrotic pallor. Now, there's other things you'd want to think of than differential. Is it reticular degeneration of like smallpox or something? Is this erythema multiforme or SGS or something of that nature? But there's a lot that goes against that. So typically, particularly for something like EM or fixed drug or SGS-TN, we like to say full thickness necrosis and death and squalor that's way out of proportion to an otherwise acute basket weave stratum corneum, which you do not see here. This is subacute and more chronic changes to the epidermis and not that acute basket weave. And then you also don't see really any infiltrate down here. You don't see any pigment dropout, although you might. You wouldn't see eosinophils if we went looking, hopefully not. So those things would help point you against those other things on the differential. Okay. So this one is, I believe, let me just double check, lichen simplex chronicus. And so, this certainly can look very similar to psoriasis, and that's why it's in this box. But there are some very important things, some important details to delineate the two. So you obviously see psoriasiform acanthosis or hyperplasia here. Now this isn't like a huge scoop or excision or something where we can really make out all the features of the acanthosis, and it kind of looks almost a little regular, but let's pretend that this is mostly irregular acanthosis. And you could, some of these are really thin and skinny, some of them are thicker in terms of width, some of them are, much deeper than others, so it's more that irregular acanthosis from an outside job. And then, so maybe you're thinking psoriasis initially, but then you get in a little bit deeper and you say, well, generally speaking, it's really just orthokeratosis. There's no confluent parakeratosis. There's no neutrophils. Now that's sort of ignoring this little section here. This little section here is from excoriation and from scratching and picking and all that type of stuff. So you have to kind of ignore that and say that generally speaking, the whole thing is orthokeratosis. There's even this pseudostratum lucidum, where it starts to look like acral skin. And then if you're lucky, somewhere like maybe here is where there's actually a hair follicle or something. That's what gives you that hairy palm sign, which you shouldn't have acral skin and then have hairs in that location. So all that goes against it being psoriasis. And then you have hypergranulosis, which usually granular layer is lost with psoriasis. And then you maybe have a little bit of an infiltrate, but not a whole lot. And so that's kind of the same as psoriasis. But another thing to distinguish the two is this papillary dermal fibrosis that's particularly with vertical streaks of collagen. So that is different from psoriasis and something that is highly characteristic of that chronic fibrosis, that chronic kind of LSC feature. And so you can see that the kind of vertical streaking of collagen. And you do get some angiofibroplasia as well. That's sort of another term for what's going on here. Looking at blood vessels isn't going to necessarily help a whole lot because you can, of course, get increased blood vessels with psoriasis as well. And then I think I maybe mentioned this, but you see all this serum crust here as well. So that's from the scratching and from maybe some oozing and whatnot, which is another thing that you should not typically see with psoriasis. You should not see that serum crust. So all those things point against this being psoriasis, and instead it's just lichen simplex chronicus. Okay, so this one is the always appreciated syphilis. And so, again, from scan, you say, oh, there's, psoriasiform acanthosis here, so maybe it's just psoriasis. And then you get in deeper and you say, well, there's confluent parakeratosis up here. There's probably some newts in there. I'll look closer here in a second. So, man, this is probably psoriasis. The one big thing that should kind of quickly push you away from psoriasis is this massive amount of infiltrate, so essentially a lichenoid band of infiltrate, and there's even a pretty substantial perivascular infiltrate as well. And anytime you see those two things together, so psoriasiform features plus lichenoid features, you got to think syphilis. You can also think MF, but you got to think syphilis. And of course, there's other features here too that you don't always see, but certainly can be helpful. So if you see these slender, so-called sexy, reedy, sure, that kind of helps point you to syphilis. That's not 100% because, and on the boards, hopefully, I'll give you a classic one, but you can have pretty thick acanthosis, and it's of course still be syphilis. There would be newts in the horn. There would be perikeratosis, and that's why it's in the newts in the horn differential, the Petrix. But you should not see, or you would probably see more serum crust and oozing and that type of stuff. And then when you get down to look at this infiltrate, and again, this isn't 100% either, but you would more than likely see tons and tons of plasma cells, which is what we see here. Pretty much all of these are plasma cells. Now, maybe that's just based on location, maybe because it's a biopsy from the groin or a biopsy from somewhere else. And so it's just location-based. But when you see this many plasma cells, and if for some of the first years, if you're still getting used to kind of what plasma cells look like, this is a great slide to do that with. So pretty much every single one of these little guys has a clock face nuclei, or a little Yoshi egg, other people call it that, for those of you who grew up Mario. And then the little perinuclear halo. Get a better picture here. So every single one of these are pretty much plasma cells. So you can look at that later if need be. But so that is syphilis. Oh, and the last thing that's supposed to go with syphilis, which it can be hard to appreciate sometimes, is endothelial swelling. Now you can get that with arthropod, just in general. You can get that with other things. But essentially what that means is, if you look here, you see a whole lot of infiltrate, but you don't really see the vessels like you normally would, because typically you'd still see the vessels, but instead the endothelial lining of the vasculature is so swollen that it just completely masked itself. Now you still see some vasculature somewhere, but let's say this is a little capillary running this way. The endothelial cells of that are thickened and swollen, and that swelling kind of almost occludes the actual vessel itself, to where it looks like you just can't even see the vessel. So it's hard to see because you're basically looking for something that you can't see, but that can be a helpful clue. Okay, this one is Geographic Tongue, which you guys don't typically biopsy, but you certainly is within your expertise to do so. Just have something to cauterize it, or I don't know, tell something to stop the bleeding. Basically, the point of this slide is just to show you that we don't really look at tongue a whole lot, although there are some characteristic features that you could see. But basically the point here is that geographic tongue, which you can get with different conditions to include psoriasis, really just looks like psoriasis. Now there's some things that are a little bit odd in this specimen. You don't necessarily see a thickened confluent perikeratosis with neutrophil's horn, because it's still mucosal. So mucosal skin is not going to really have that thickened stratum corneum per se. But if you look in here, you do see a whole lot of neutrophils in a slightly thickened mucosal horn. And that brings up a differential. That does not mean that this is absolutely psoriasis. You could still, it could still be anything. That Petrix differential could be candida. I mean, it wouldn't be sebderm, but it can be other things, infection. There's other things that can happen in the mouth, infection-wise, that can produce this a similar appearance. But basically, it's a psoriasiform acanthosis, because you still get acanthosis. It's not supposed to be that thick, and then the neutrophils in the mucosal horn. And other features of this being mucosal skin are the lots and lots of vessels, plus skeletal muscle. Now with the tongue, usually you get a ton of skeletal muscle if it was a deeper biopsy. But that's just geographic tongue. And it's unlikely to be on your boards. Okay. So this one, I think, is just subacute sponge. Let me check. So this is the dreaded subacute sponge. This is the one, as I was alluding to before, that's always frustrating when you get this back as a biopsy report, because it really doesn't help you at all. Remember that many of us appreciate that and remember that, and we would rather not give you that diagnosis if we could. But as the point of this slide is that's sometimes all you get, and that's all you can say. And it's completely impossible to try to say anything else more specific that might be going on. And as best as we can, we'll try to search for eosinophils and try to search for other stuff that may help a tiny bit. But basically, the salient features here that show a subacute process are, instead of a bascoe stratum corneum, that would imply more of an acute process, you have a compact kind of subacute horn. So it's more this compact ortho and parakeratosis with some serum crust in there. So remember that serum crust kind of goes a little bit against psoriasis. Plus, you don't see tons and tons of neutrophils in here. So, there's maybe a few here and there, but it's not a confluent parakeratosis with layering of neutrophils, so less likely for it to be psoriasis. Plus, you get quite a bit of spongiosis here in the actual epidermis. So spongiosis, generally speaking, goes against psoriasis, except for those few types. And you do have some lymphocytes in here, but not a whole lot. They're more just coming up from exocytosis. And they're not necessarily tagging the DEJ. It's not producing a vacuolar interface pattern, so it's not going to be MF. And then all you have here is just a kind of a medium perivascular infiltrate that's predominantly lymphocytic. We would normally hunt around and see if there's any eosinophils at all, because maybe that helps justify, like, oh, it's allergic contact derm or a bug bite or something of that nature. But this really just brings up a differential. A very unsatisfying result. Okay, so 13. This is porokeratosis. This one, of course, everyone loves to get on boards or tests of things, because as long as you don't miss the cornoid lamella, you say porokeratosis and you move on. The only reason why it's really in this box is because in between the cornoid lamella, the little choo-choo train smokestack here, in between there, you can have anything. Anything goes. So in this case, it's kind of almost psoriasiform hyperplasia of the epidermis with what looks to be, confluent perikeratosis. There really shouldn't be any newts in there, though. But it kind of looks almost psoriasiform. And so if you weren't really looking, this is why early on you hate looking at things from scan. You always want to dive in deep. But this is one of the things where you could kind of miss it at scan if you threw this up there and then immediately kind of jumped down and you're thinking, oh, this is probably psoriasis, this is going to be awesome. And then you're like, yeah, there's confluent perikeratosis, and yeah, there's not a whole lot of newts, but I could still make this into psoriasis. And then you miss the ginormous, cornoid lamella here on the edge. And so anything goes inside of porokeratosis. It can be lichenoid, it can be atrophic, it can be psoriasiform. But this column of perikeratosis with not only diminished and loss of the granular layer, but also some dyskeratotic cells, so almost kind of maybe forming corons and grains and that type of stuff. That goes with the cornoid lamella and porokeratosis. Okay, we'll go through the last few pretty quickly because there's some duplicates. Let's see, what was this one? This one I think is PRP. Nope, this was just psoriasis. So I'll kind of just skip this one since we spent a lot of time on psoriasis, but basically this is another example, though, of how you don't necessarily get classic features. It's kind of more spotty perikeratosis and neutrophils. So a lot of times when we biopsy psoriasis, it's not classic psoriasis, but you do have pretty regular acanthosis, not a whole lot of spongiosis, not a whole lot of infiltrate, kind of some thinning of the suprapapillary plates, and then there's neutrophils up there. So it brings up the differential, a Petrix differential. You still want to consider tinea and all that type of stuff. And that one was psoriasis. Oh, that's right. This is another pityriasis rosea. I think this is the one that had the 45-degree angle thing a little bit better. So you can see here, you don't always see this, but you have to kind of use your derm path imagination skills. But basically, little focus of perikeratosis, no neutrophils. Maybe it even has the teapot sign if it was kind of angled up for whatever reason. At roughly 45 degrees, this is kind of directly underneath it, but at roughly 45 degrees you see a focus of spongiosis, and then roughly 45 degrees a fairly dense focus of lymphocytic infiltrate. All that goes with pityriasis rosea, with the infiltrate expanding outward this way and leaving a trailing scale behind it. Pityriasis rosea. This one. oh, this one's candidiasis. I'll kind of just briefly go through this one. The point here is that I think somewhere on one of these cuts, yeah, way down here where the glass slide isn't that great, somewhere down here there's an itty-bitty tiny little subcorneal pustule, and I think somewhere over here as well. But, you know, it brings up a differential. So this is a subcorneal pustule. That's why P tricks. The C is candidiasis. And if you look down in here even closer, you don't want to stain this, but you'd actually start to see little pseudohyphae and spores and whatnot. Actually, if you put down the condenser, you can almost see it a little bit better. Kind of see in here little pseudohyphae and spores and whatnot. Just use your imagination. They're there. That's candidiasis. Subcorneal pustule. Okay. 17. So this one is just Stasis Dermatitis, and it's in this chapter because you get, classically, you get a subacute spongiotic process, and it can also sometimes develop some psoriasiform changes, so very much kind of both features. What goes for Stasis Dermatitis in this case, and this one pretty much has all the classic features, is from scan, you notice that there is no basket weave stratum corneum. It's a compact stratum corneum, meaning that there's probably something that's been going on here for a while, kind of subacutely, chronically. There's a little bit of acanthosis of the epidermis, again speaking to kind of more of a chronic process, but certainly not like a regular acanthosis, I suppose. And then underneath it, you've got some pigment that you can see from scan even, and we'll get down deeper here in a second. And then all this stuff, these vessels, particularly the papillary dermis. And so again, a little closer, you see, confluent, compact horn, not really tons of neutrophils, but if it's secondarily impetiginized, certainly you could see that acanthosis. And then all this is hemosiderin, so it's not melanin. It's hemosiderin, and you can, if it's a darker skinned person, you certainly can get PIH in those areas, and so there might actually be true melanin as well. But in this case, all this is that hemosiderin, which is giving it that cayenne pepper look or Stasis Dermatitis look. Sorry, I use cayenne pepper. That's kind of more Schomburg's, which is technically a PPD, but similar in the sense that it's hemosiderin and producing that color change that you notice clinically. And then the big thing here is the nodular angioplasia or cannonball angioplasia that's occurring, and that's all these vessels. And what we see in the dermopath world is pretty much anything that you biopsy from the lower extremities, you'll see this stuff. And so, especially in America, just from age and from weight and all that sort of stuff, even without producing clinical stasis dermatitis, we can sometimes say, oh, is this a basal cell on the lower extremities? And because we see a basal cell, and then we see all this angioplasia and some hemosiderin. And so it's just features of being in a very dependent location and very normal changes that occur over time. But this is not a capillary malformation. This is not a some sort of hemangioma. This is just nodular angioplasia in response to the stasis dermatitis. And again, all this is hemosiderin. Sometimes it can be difficult to distinguish between melanin, but if you do the little fake polarizing thing, it is refractile, kind of like red blood cells, and so whereas melanin is absolutely not refractile. And then if you look closer at it, really close, if it's more of a yellow-brownish appearance and you have huge granules, that is much more likely to be hemosiderin than melanin. And of course you can stain it and use iron stains and all that sort of stuff and truly tell the difference if it's very difficult. Okay. So this is granular perikeratosis. This is not the best example ever, but remember that this is one of the exceptions to the rule, because under perikeratosis you typically get loss of the granular layer, whereas in granular perikeratosis you still have retention of the granular layer. Now I say that knowing that in this particular cut you can't really find a granular layer, but it actually is there, and what makes this still granular perikeratosis is that in granular perikeratosis you don't just get retention or sometimes hypergranulosis, so retention of that granular layer, you also get granules in the stratum corneum. And so if we get really, really close, which again, this isn't a perfect cut, but when you get this on a test, sorry, I know that was horrible. Well, it's hard to see on this one, but in here there are still granules. So there's granules in the stratum corneum that only occurs in granular parakeratosis, and then maybe you get some retention of the granular there. Just use your dermatopath imagination goggles on that one. Okay, so this is, just make sure, Pityriasis rubopolaris. Yep. And there are some important features. We'll kind of end with this one. The next one's sebderm and super quick. So with PRP, you can get a psoriasiform acanthosis of the epidermis, but usually it's not nearly as pronounced as psoriasis. It is, instead of having thinning of the suprapapillary plates, you get thickening of the suprapapillary plates. So we'll kind of come in here a little bit further, and you can see that, maybe you can imagine that that's not as thinned appearance as you saw in psoriasis. And then in the in the stratum corneum, you do see parakeratosis, but it's more that checkerboard pattern. And this is pretty good for it. It's never going to be as good as the textbooks, but in this case, you do see, basically para and ortho and para and ortho, and just ignore these neutrophils. So there's more para and ortho. So it's kind of this checkerboard pattern. You shouldn't see a whole lot of neutrophils in the stratum corneum because that would kind of go more with psoriasis. You can see a little bit more spongiosis in PRP than you typically don't see spongiosis in psoriasis. You can actually start to get acantholysis in PRP, and if you see that, that's actually pretty good for it. With PRP, you get follicular plugging as well. So if you find, ignore those neutrophils there. If you find, hair follicle and it's kind of more like you see some plugging there, that goes with it as well. And that's pretty much it. So yeah, there's maybe some plugging here as well. So all those things are features of PRP, but that can be sometimes hard to. They're very subtle features. We have one recently, and we went over with Maze. For sebderm, really, it's in the psoriasiform box, of course, and there's maybe a spectrum. We like to talk about pseudosporiasis and whatnot. In histopathologically speaking, what you want to look for is little areas of parakeratosis with newts that are particularly located next to follicular ostia. And then there's usually a little bit more sponge than there is in psoriasis, and it could be a biopsy from the face or maybe scalp or something. But otherwise, it is very similar to psoriasis, maybe some thinning of the suprapapillary plates, dilation of vasculature. So that's sebderm compared to psoriasis. And that's it. Any questions?
Thanks, Justin.
Yeah. No problem.